A lot of people have questions about different things that they see on social media or that family members tell them. And nicotine has come up several times. So I said, okay, I'm going to dig into this. It's something that I've read about and learned about, but I wanted to talk about it from a healthcare perspective. And I want to start by offering a disclaimer. We have some people on in our organization that might feel like, oh my gosh, Randy's off his rocker. He's promoting nicotine. So I want to be very careful to start with this disclaimer, right? I'm a nurse practitioner and I'm the chief medical officer for A Mind for All Seasons. And this presentation is not to promote the use of nicotine. It's really just a masterclass. And I'm not encouraging you to start it. I'm not saying you should add it as a supplement. And I recognize there's some potential for addiction if you use nicotine. But the purpose of this masterclass is education, and it's an answer to many of your questions. And I do think it may or it could fit into a personalized treatment plan for those at the highest risks of neurological disorders. So I'm a very open-minded guy. And so don't walk away and say, oh my gosh, he's wanting everyone to start nicotine. That's not what I'm saying. This is an educational class. And to show you, this is a quick video that I recorded about our website. If you go to community@amindforallseasons.com and click up there in the upper left-hand corner where it says feed, you as our clients and members can post articles about questions that you have, and I'm happy to take those questions and prepare a summary. So I've scrolled through a bunch of questions. I'm active on this site. I try to respond to your statements and your questions. This is one that came up about nicotine a couple of weeks ago, and I thought, okay, I'm going to dig deeper and prepare a little summary about that. So thank you for posting it. You're welcome to post whatever you want up there. Obviously, it has to fit our community guidelines and be respectful, but then I'll take that information and try to prepare master classes out of that. My goal today is to say there is a difference between nicotine that comes from tobacco and synthetic nicotine. And I would never advocate for nicotine from tobacco, only synthetic. And why is it and why are people talking about it? Or what options would you use it in? What doses? Is there research that supports the use of nicotine in Parkinson's disease or in Alzheimer's disease? And then I'm going to finish with my thoughts and impressions of who would be a really good candidate to consider this. Or maybe I should say, who would be a candidate to consider the use of nicotine if you're really struggling with neurological challenges? Okay. So first of all, as a starting point, everyone is familiar with nicotine because it comes in tobacco, right? So there's a big tobacco field that you can see, and those are big tobacco leaves. And then I've put up there the chemical structure of what nicotine is. Well, when you smoke a cigarette has a lot of problems. There's a lot of chemicals in that cigarette that are known carcinogens, and they're also known dementogens, right? A carcinogen leads to cancer and a dementogen leads to dementia. But one of those chemicals that's in tobacco is nicotine. And nicotine is just one of many chemicals that is in tobacco. And so nicotine is the part that probably makes an individual want to keep smoking. I said us, I don't smoke. I've never smoked. But this is something that probably makes an individual want to come back to nicotine or to tobacco. It has an addictive quality. So to be clear, tobacco-derived nicotine, even though we can separate nicotine from tobacco, it's still thought to contain carcinogens from that tobacco plant that has risks. And so generally speaking in the medical community, it's not advocated to use any form of nicotine that comes from tobacco. So where the heck are you going to get it? It's synthetically derived. It's made. This is a completely synthetic product of nicotine. It's made in a laboratory. And so it's often referred to as a tobacco-free nicotine, right? And the base chemicals are vitamin B3. It comes from nicotinic acid, ethyl nicotinate, which is a derivative of vitamin B, and myosamine. Okay, so it's clinically identical to the nicotine in tobacco, but it doesn't have all those carcinogenic properties, cancer-causing properties that would be an issue. And so if a person with some form of neurological disorder wanted to use nicotine, they use a synthetic form because it's been purified. It's free of all those tobacco impurities that are called tobacco-specific nitrosamines, okay? It's consistent in its dosing. So when we create nicotine in a laboratory, it comes out as two chemicals. One's called S-nicotine and one's called R-nicotine. For those of you who are science buffs, those are stereoisomers of each other, right? And then it can be flavored because nicotine from tobacco has a tobacco taste to it, but you see people running around with these vape machines and they're puffing vapes and they have all types of flavors because they feel the report is that this contributes in some way to the enjoyment of consuming nicotine instead of having it like the nicotine flavor. So I took a short video off of YouTube. This is from the Wall Street Journal, and I've only taken about 2 minutes of this, so I want to play this for you. This talks about synthetic nicotine.
I don't hear any
Andy,
audio.
we're not getting sound.
Oh, you don't get any sound from it? Oh, I hate it when I do that. Let me stop sharing my screen. And let me make sure I share it again. All right. And now let's share. And I tried to optimize that for sound, but maybe I blew it. Okay, let's try it again. Eric, tell me if you hear the sound.
These white pouches
Yeah, we're good.
are the future of the tobacco industry, but there's no tobacco inside.
The main ingredient inside Zins is pure nicotine.
These are Zyn nicotine pouches. The oral nicotine product comes in these cans. You may have seen them for sale in convenience stores, gas stations, and even your local pharmacy.
You see, they're all
Or
tobacco
on social
free.
media, where they've birthed a devoted subculture.
Good morning, boys. Popping a little.
Over the past year, sales of Zyn have skyrocketed. In the fourth quarter of 2023, 116 million cans were sold in the US, a 78% increase over the same period a year earlier.
Zyn is definitely having a moment.
Pouch packed with problems.
But Zyn's remarkable success has provoked a backlash and thrust it into the culture war.
Many people see it as a threat.
So, what can we learn about Zyn when we test it in a lab? And how transformative a product could Zyn be for the tobacco industry?
Today we're going to be finding out what's in Zins.
Ben Katz is an analytical chemist at UC Irvine, specializing in mass spectrometry. Outside of his university work, Katz has been testing nicotine pouch products.
What's in the pouch? Spearmint edition.
And sharing the findings on his TikTok channel, Mass Spec Everything.
Now we're going to test a chill, the wintergreen.
Today, Katz is testing 6 different Zyn flavors.
All right, so now we're going to be analyzing the samples on the mass spectrometer. A mass spectrometer is capable of weighing the exact mass of a molecule so that you can determine the composition of the chemical structure and identify what is in a sample.
Oh, it works.
In the data analysis software, we see a series of peaks. There is a common peak that's in all of the samples, and it's the most abundant peak in all the samples. That is our nicotine peak. Based on these tests, nicotine is the bioactive molecule in Zyn, and the nicotine is the only tobacco-related alkaloid that we can see in this product.
Zyn looks like a little tea bag. It's a tiny little white pouch that tucks inside the cheek, and inside there's no tobacco leaf. There is cellulose or wood pulp, along with some artificial sweeteners and flavorings and nicotine.
Okay, so If you're interested, like if this is a topic that really strikes you, this is an 8-minute summary about the science of synthetic nicotine. And so I posted that there. You can take a picture of that and you can see, well, what is in this synthetic product? But I wanted you to see that they've tested these in labs. These are third party. So this is not this company testing them, but it's a third party university base that says, okay, this is not a tobacco-derived nicotine. This is 100% synthetic. We've tested multiple products over and over, and it's consistent. This is a synthetic nicotine. And the reason that I wanted to point that out is if you're struggling with neurological disorder and you want to try nicotine, you have to be thoughtful about what you get. So I'm going to walk through a couple of different products. And I was dumbfounded how many products there are on the market, right? So I'm going to point out things to you so that you can see this. These are all over the counter. This is a product called Tone, or 20NE. I don't know how you say it. Lots of different flavors, and this is an 8 milligram pouch for nicotine, right? Similar to what you just saw. There's another one. I thought this was interesting. This is a company called Athletic Nicotine. Well, look at it. Really? Athletes use nicotine? Apparently it's more common than I imagined. So you can get this in a 3 milligram, a 1.5, or an 8 milligram. And these guys advertise to the athletic market, the bodybuilding market. Nicotine is oftentimes used just like a bodybuilder would use caffeine in a pre-workout meal. There's another form. Look at all this. This is Velo. Here's a 6 milligram, a 9 milligram, a 12, an 18, a 20 milligram. So you see the same company produces all different products, different flavors and different strengths in their product. Another one is called Breakers. This is a product by Lucy. They kind of candified this. So it has a little bit of nicotine in it, and then you'll see that yellow dot in the middle has a flavoring to it. So if you were to bite down on that, it kind of bursts in your mouth and you get whatever this flavor is of mango or apple cider or whatever. These come in 4 and 8 milligram strengths. There's gum. Everyone's familiar with gum. We've heard of Nicorette. I've heard of that my whole life. There's lots of different brands of gum, and you can see that the gums come in a 2 milligram or a 4 milligram or a 6 milligram. And that's a 9-pack, right? So you get 9 in there. If you were to go to Walgreens and buy nicotine, look at the difference. This is a 2 milligram strength, and there's 160 in it. So if I go back to this previous one, this is only an 8-pack, and it has multiple different strengths, or excuse me, this is a 9-pack with multiple different strengths, and this is a 160-pack. So why am I pointing this out? I can't believe the different dosages, the different flavors, and the cost associated with this type of nicotine. It is all across the board. Some of them very, very expensive, others quite cheap. There's transdermal nicotine patches. You've all heard of that. I'm very familiar with that, having practiced medicine now for 20 plus years. I've recommended these in many cases. The patches come, the lowest dose is a 7 milligram. There's a 14 milligram and a 21 milligram patch. I didn't know this. There's toothpicks. You can get a Zippix. It's a nicotine-infused toothpick. They come in 2 milligram strength. So 2 milligrams is the lowest dose that I could find, as I spent a fair amount of time looking at all the different nicotine products. I thought this company was interesting because they also have a caffeine B12 product. So that's not a nicotine product, but I thought, oh my gosh, I thought I was aware of all the different ways you could use caffeine. I didn't know there was a caffeine toothpick that you could put in your mouth that has a little vitamin B12 and caffeine. I thought that was pretty fascinating. Okay, you see this everywhere you go. People sitting in their car, walking down the street that carry these little vape devices, and they suck on it and put out this huge puff that just evaporates into thin air. One advantage of this is when I walk through a puff of someone's vape, it doesn't smell like tobacco, right? It oftentimes smells like pina colada or something like that. And they come in all different strengths as well. So there's 0 milligram for people who just want to vape, but apparently not have nicotine. And then they come in different strengths. There's a 0.3%, a 0.6%, a 1.2%, and a 1.8. And these correlate with how significant the nicotine load is in each vape. To me, this would be the most risky, because I see people that hold these vape pens and they'll vape 10 times a minute and they hold it all day long. These are massive doses of nicotine that people get. And I think, oh my gosh, that, to me, I would be very careful. Maybe they're using a small amount, right? I'm not meant to be judgmental here, but my thought is we should be thoughtful, especially in the setting where we're not using it to try to come off cigarettes. There might be some thought about, could this help me neurologically? Okay, so let me talk specifically about that thought. Nicotine and cognition. This is where I'm going to get a little bit more scientific. So I wanted to show you what's out there. Now I'm going to play doctor with you and say, okay, what happens with nicotine and cognition? When nicotine gets into the body, it binds to a receptor, and that receptor is called the nicotinic acetylcholine receptor. And the acronym there is the NACHR''S, right? Nicotinic receptor. Well, if you go to a neurologist and you're diagnosed with dementia, your neurologist is going to prescribe a medicine that also binds to that exact same receptor. And that prescription medicine is called donepezil. Donepezil is FDA approved for the treatment of Alzheimer's dementia, and its goal is to slow the memory loss down. That's what it's designed to do. So it binds to the exact same receptor that nicotine binds to. And when you get your roadmap, I don't prescribe donepezil, I have. And if someone asks me in a telemedicine consult, I want to use donepezil, I will prescribe it. I don't have a strong affinity for this medicine, but I'm also not opposed to its use. It kind of depends on the person. There are some risks of that medicine. But in your roadmap, I always recommend a supplement called acetyl CH active. And acetyl CH active is designed to bind to those exact same receptors. And there is some research about using choline or choline alpha GPC or huperzine A. These are ingredients in that supplement right there, acetyl CH, that also play on that nicotine acetylcholine receptor. And these have been shown to improve your attention a little bit, improve your working memory. They can strengthen reaction time, fine motor skills, improve your alertness, right? Your level of orientation. These are things that go south in individuals that have dementia. Nicotine also binds to some receptors and has some influences in the dopamine pathway and the norepinephrine pathway. This is a very stimulatory pathway in the body. It's often referred to as the reward pathway. So this is why nicotine's addictive, right? Because it makes us feel really good. It's a nice reward. It's called the feel-good pathway. When people smoke, they go outside and take a smoke break from their work, and it just makes them feel good. It gives them a little bit of a rush. It's also the stimulant pathway. When someone has attention deficit or ADHD, we give them medicines like Ritalin and Adderall that also hit this exact same dopamine pathway. Excuse me, I had a cough. It will stimulate your level of alertness and stimulate your focus. But the problem is the more that we stimulate that pathway, the more there's a chance we can develop a dependency to and or a withdrawal when we stop using that. And so any individual who has smoked in their lifetime and they work so hard to get off tobacco knows how freaking hard that is, right? Just that nicotine dependence. And so one of the hesitations I have in making this recommendation is, hey, if we do this short term, do we turn on those receptors of dependency or withdrawal? And if we turn them on, is it hard to turn them off? Like what if one of our clients is a historical smoker that spent a long time trying to stop smoking, and then I came back and said, hey, why don't you reconsider nicotine? That creates a little bit of some cognitive dissonance and could create a problem. So people just have to beware. Is there some science there? Yes, there is. But just like all things in life, there's a potential benefit and a potential drawback. So, people will say, well, what about modest doses, Randy? Is there a risk if I have modest doses? And my response is, it's probably low because look, a lot of people wake up every day and have a cup of coffee or they have a little bit of nicotine. And to me, that's very different than pounding a Red Bull or a Monster several times during the day, right? Dosing actually matters. And we've all heard of teenagers who drink 2 or 3 Monsters and end up in the urgent care because they're in tachycardia or they have AFib and they go to the hospital, and after it wears off, they're fine. And the cardiologist says, yeah, you need to tone down your caffeine use because you got 800 milligrams in the last 6 hours. It's just kicking your butt. So a small amount of caffeine or a small amount of nicotine probably isn't very harmful. But if the use of those products grows and it extends into repeating over and over and over through the day and the dosing gets higher, then obviously the risk becomes amplified. And it's probably more a risk of a tolerance of these products. They do have some cardiovascular stimulation. So if you had AFib or cardiovascular disease, or you're a nervous nilly and always anxious, we probably don't want to hit you with a bunch of norepinephrine and stimulate you nonstop. You see my point. So what would be considered modest dosing? Well, it was very intentional when I walked you through all the dosing of those different products. So modest dosing would be like a 2 milligram Nicorette piece of gum or a 2 milligram Zippix toothpick. If you wanted to use a transdermal patch, the lowest dose of the patch is 7 milligrams, and we're told you shouldn't cut the patches. It changes the absorption. And so that is what would be considered modest dosing. Now, as a part of my science experiment, I like to do science experiments. I have a friend who uses nicotine pouches all the time, and I said, hey, I want to try a nicotine pouch. I want to see what it makes me feel like. Now, I've never used nicotine in my life, but I thought, well, I'm going to use a pouch so I can talk about this. It was a 3 milligram pouch, and when I put it in my mouth, within about 15 minutes, I felt lightheaded, and I could tell, wow, it was fired up. I didn't like the feeling. So 3 milligrams was way too much for me. I would be one that would probably, if I wanted to try this, I might get a Nicorette gum and cut it into fourths and try a 0.5 milligram and use a half of this if I wanted to give this a trial. So remember, even modest dosing to someone who's nicotine naive may be too much, as was my little personal science experiment. So let me walk into what the science actually says. In 2012, there was a study that was funded by the Michael J. Fox Foundation for the treatment of Parkinson's disease. And the title of the study was "A Nicotine Patch Can Slow Memory Loss for those that have mild cognitive impairment." And so they did this study. Let me tell you what the results of the study were. There were 74 participants with the average age of 76 years old. So we're using this in seniors. And they did a 6-month clinical trial through Vanderbilt University. So this is very scientific in nature. They looked at parameters that focused on attention, memory, and cognitive impairments. That's really what they were looking at. And they were basing this off a clinical trial that was done by the American Academy of Neurology, looking at nicotine patches and their potential to show benefit in cognitive impairment. So in the nicotine-treated group, 46% regained some normal performance for age in long-term memory, but the placebo group that was also using a placebo of nicotine continued to worsen in their cognitive decline by 26%. Now, remember, these sound like big numbers, 26 and 46%. These are relative, and I don't have time today to go into relative and absolute. These were not massive improvements, they were modest improvements, okay? But they showed 46% of the people using nicotine, that's more than half of them, had some improvement in their attention span, their memory, and in cognitive impairment. So they went on and did a trial in Parkinson's disease, and this was using transdermal nicotine. Again, this study funded by the Michael J. Fox Foundation. And specifically in Parkinson's disease, the reason they funded this trial is that when we look at longitudinal studies, right, we take huge groups of people. We take people who have been smokers for a long time. They appear to have less of an onset of Parkinson's disease than the population who is non-smokers. So we look at this and we don't know why. Well, what is it about smokers where they have less Parkinson's disease? It can't be all those stinking carcinogens, so it must be the nicotine. That's the thought process. So they have a preclinical trial, phase 2 clinical trial that was completed that shows that nicotine does have some benefit. And what are the benefits in those Parkinson's disease patients? Little bit better attention and working memory, better reaction time. Now think of a Parkinson's patient. They don't have great reaction time. They're slow, they're stiff, they don't move very well. And so their fine motor skills got a little bit better. Their episodic memory, alertness, and orientation got a little bit better. So interesting, right? Nicotine is very widely available. You don't have to have a prescription from your doctor. Let's say you have Parkinson's disease and you're on Cinemet and it makes you constipated and you don't feel good. Well, it'd be really easy to go get a little bit of nicotine because it's relatively safe. It's been used 1 billion times on this planet, right? And relatively safe, and you don't have to have a prescription to get it. And there continues to be ongoing double-blinded studies using nicotine patches and placebos. And right now there's 20 clinical sites in the United States and in Germany running clinical trials. And remember, this is in Parkinson's disease. So you have to figure out who's a Parkinson's patient, who's willing to do it. You have to meet certain criteria. So they're looking at a treatment goal of looking at 160 people for a long period of time. It takes a lot of money to fund these clinical trials. And the hypothesis that underpins these clinical studies is that nicotine helps to protect the neurons in the brain that make dopamine. So we're trying to protect them so they don't die off, but we don't lose them over the course of this awful disease of Parkinson's disease. I could get into the deep science. I don't think our group really wants me to talk about chemical receptors and how they work, but I just want you to know that there's, in reading through this, I read through all the clinical science. I've been aware of it, but there was a little bit more focus. And today, or in this study, I looked at COVID. There was a fair amount talking about how nicotine can impact COVID or COVID long hauler syndrome. And we have some people that are a part of our program that are here because they have COVID long hauler syndrome. Now, what's interesting in this was not a study. This was a series of case summaries or trials. So they took certain individuals that were not responding to other COVID long hauler treatments, and they put them on a nicotine patch. And you'll see that the nicotine patch is listed in red. When they did those clinical trials with nicotine patch, nicotine soared in the body, and then they started looking at all of these other symptoms. And you'll see over time, the symptoms got better and better and better until eventually by day 20, the symptoms have really faded. So that was a 19-year-old male with COVID long hauler syndrome. Here's a 31-year-old female, same thing, right? She had terrible headaches and had exercise intolerance. And when she used a nicotine patch, here's the dose of the nicotine patch, and then it stops. So these people are using one patch for 1 week, and you'll see all of these symptoms whittle down. So there was a fair amount in this summary of case studies that nicotine was really helpful for people with COVID long haulers. Here's a 41-year-old male, same thing. Here's a 52-year-old male that used a nicotine patch, and you see the serum levels of nicotine that were tested. And then as they come down, many of their symptoms got significantly better by the end. So even though a case history is not a clinical trial or a study, Man, I live my life talking to folks like you. Each one of you are a case study. Each one of you individually are working through a process to optimize your cognitive impairment. And so for that reason, I really like case trials. So when would I say you may be a candidate for a nicotine trial? Well, let me walk you through this. First of all, I would never say right off the bat in someone's roadmap, oh, hurry and jump on nicotine. I would not do that. These are the people that I would do a clinical trial with. I would say, okay, have you embraced all the lifestyle changes that we've talked about? Are you exercising every day? Did you clean up your diet? Are you getting better sleep? Are there efforts to reduce stress, right? Some people may go to therapy. Some people may do squared breathing. Other people get in a sauna or a cold plunge. They have an active effort to reduce stress. Some people do audiovisual entrainment or David Delight. We've been doing that now for 8 years. I want you to make sure your dental health is good and that you do brain training and brain stimulation every day. And then I would say, and I want to see your lab work first. Do you have low levels of inflammation? What's your CRP level and your AG ratio and homocysteine? Have we optimized all your nutrients, right? Thiamine, B6, B9, B12, vitamin E, omegas, your antioxidants. What's your blood sugar, insulin, A1C, and uric acid? I'm paying attention to your labs. The next thing I would ask you is, are we controlling for your medical problems? Because if you got raging diabetes and you're not correcting that, or your gut health is in the toilet, then I have a low level of confidence that nicotine is going to push you over the edge. You got to clean these things up. You got to dial in autoimmune disease. If you've had a concussion, we got to work through some concussion management issues because that causes long-term neurodegenerative problems. And then I would say there's a group of supplements that are not habit forming. There's no risk that you're going to get addicted to it or develop tolerance. And there's actually really good research about them. Are you using acetyl CH active? I already talked about that. That's the very nootropic that stimulates the nicotinic acetylcholinergic receptor. You might try dopatone for people that have ADHD, vinpocetine, or do an omega challenge and a glutathione challenge and a ketone challenge, right? These things make a difference. And then I'll say you might also consider other brain strengthening therapies like exercise with oxygen or hyperbaric medicine, interactive metronome, red light therapy, sauna therapy. You see my point. There's a lot of legwork that should be done before we just go start jumping on the nicotine bandwagon. That's my personal opinion. And then I would say, what is your definitive diagnosis? Well, there's people who say, Randy, I've tried everything that you've asked me, and I've actually had limited improvement. We're missing something. That would be a person I'd say, okay, maybe let's try a short amount of nicotine. Let's see if we can hit that receptor. What if you've definitively been diagnosed with Parkinson's or Alzheimer's or frontotemporal lobe dementia? I have a patient with wicked autoimmune disease. She has celiac disease and lupus. She's been on all of these disease modifying medications and just really feels crappy. We did a nicotine trial with her and she's actually done very well. She feels better. To me, that's very justifiable when she's done all of these other things. There's a lot of cancer survivors that have chemo brain or COVID long hauler survivors where we just haven't seemed to make a big difference. And in those cases, then I would say, let's introduce a little bit of low dose nicotine, maybe 1 to 2 milligrams, expanding into 2 or 3 times a day, or start a nicotine patch where it's transdermal and you wear it and it goes all day long. So if I was to summarize these, this is kind of my list of when would Randy consider a trial. I have a number of clients, if I get down to the bottom, that I have one client that has Parkinson's disease that got a neurological stimulator put in his brain to try to tone down his Parkinson's disease. I would do a nicotine trial before that because that's a brain surgery with lots of risks associated. Why wouldn't you try that? I see so many patients that have had chemotherapy and they come back saying, man, I've got chemo brain. I'm doing everything you've asked me to do. Is there anything else I can do? And the last one is quality of life. I have a number of clients who they are in advanced stages of Alzheimer's disease. And we're kind of at the point where we've got to consider, let's put them on an antipsychotic medicine that's typically used for people with schizophrenia or bipolar disease. There's risks associated with those medicines. And in my opinion, the risks with those medicines are greater than the risks of nicotine. So could we do a little nicotine trial with those patients and see if it helps them a little bit? I think there's good rationale in that kind of a trial. I would totally support that. Okay. So when would I not consider a trial? Well, the first one is if you have a history of smoking, nicotine may just turn that right back on and just create some problems for these people. These are not hard, fast lines, but these are things I'd be really thoughtful about. If you have addiction issues, right? So we'd have to be careful with higher doses, higher frequency. I would really discourage inhaling nicotine, kind of like the vape. That just hits those dopamine receptors so quickly, and it's so apt to turn on those addiction issues. So I would be cautious about that. People who have poorly controlled blood pressure or a really elevated heart rate, like an atrial fib, the science is not really supportive of a nicotine trial in those cases because it can have some cardiovascular stimulation we have to be careful about. Current use of a stimulant. What if people come to me and they take Ritalin or they take Adderall and they use caffeine several times a day, and now we're adding another stimulant like nicotine? I think at some point we tap out of just trying to whip the brain, right? Nicotine, Ritalin, Adderall, caffeine, it's just whip, whip, whip. We're just trying to whip your brain into being more alert. I think we would be careful in those instances. And I would never recommend this in a young adult or a developing teenager. We know that the brain doesn't even fully develop until 25, 26, 27 years old. And if you're me, and my brain probably didn't fully develop till I was in my 30s, right? I was just a dingbat growing up. So we just have to be careful of and be thoughtful of the population. More and more, I'm taking care of a younger population, individuals with major depression or suicidal thinking, people who have had head injuries when they played high school football. Just yesterday, I had a football player from Idaho State University that got a concussion his sophomore year of football, and he could never clear the concussion protocol for a solid year. And so the team cut his scholarship. He quit football, and he's just been trying to pick up a shattered life since then. I saw him yesterday. He's now 24 years old. I wouldn't recommend nicotine in him. There's so many other things that we can try first. So that goes into my consideration of when wouldn't I do it. All right. So I've tried to give you a good overview. I've tried to give you some of the science. And then I've tried to give you a little bit of Randy Vaudry, a little bit of my perspective of when this would be considered appropriate, when it wouldn't be considered appropriate.